I chose to research phonatory strengthening exercises on improving vocal function related to voice-related quality of life. The first article in my literature review is called Voice-Related Quality of Life Following Type 1 Thyroplasty for Unilateral Vocal Fold Paralysis. This study was conducted to analyze the voice-related quality of life, or VRQOL scores, of individuals who have undergone type 1 thyroplasty for unilateral vocal fold paralysis to those individuals who have not been treated and to norms. In this study, there were 3 groups. The first group had 30 individuals who were in the treated group, which were the individuals post-type 1 thyroplasty, and 17 dysphonic participants were in the untreated group, and 22 individuals with normal vocal quality in the third group. Each group was given the VRQOL and scores were recorded. The untreated patients rated their voice as poor, treated patients rated their voice as very good, and normal voiced individuals rated their voice as excellent. The second article in my literature review is called Efficacy of Vocal Function Exercises as a Method of Improving Voice Production. This was research to determine the effectiveness of vocal function exercises on individuals with no history of voice disorders. The participants were divided into 3 groups: an experimental group with 12 participants which engaged in vocal function exercises, a placebo group with 11 participants which engaged in placebo exercises, and a control group with 12 participants which engaged in vocal abuse. The experimental and the placebo groups were given their exercises and told to do them twice a day, every day for 28 days. 3 times a week, the participants were assisted in the exercises by a graduate clinician. The control group only engaged in vocal abuse. Pre- and post data were measured by VisiPitch. The results showed that the placebo group demonstrated no change in pre- and post measures, yet they commented positively about the program, which may have been due to increased awareness of vocal production. The experimental group demonstrated significant changes in phonation volume, flow rate, maximum phonation times, and frequency range. Notable discussion for the first article is within the treated group, individuals over 2 years post-surgery had significantly lower ratings than those patients 1 year post their type 1 thyroplasty. And these results could be due to an actual decline of vocal quality over the years, or that vocal capabilities remained the same, but the patient's expectations became higher with time. This first article is related to my study because I used the voice-related quality of life quiz as a pre- and post-therapy measure. As far as the second article, this article is relevant to my study because vocal function exercises were the targeted therapy procedure used to increase loudness and quality of voice for the patient. The third article for my literature review is called Effects of Compliance Monitoring of Vocal Function Exercises on Voice Outcome Measures for Normal Voice. Here, Ellis and colleagues conducted a research study on individuals with normal voice to measure the efficacy and effectiveness of vocal functioning exercises. 20 graduate students with no history of voice disorders were randomly divided into 2 groups, a monitored performance group with 10 participants and an unmonitored performance group with 10 participants. The participants in the monitored group recorded and submit each of their daily vocal function exercises, while those in the unmonitored group were simply expected to complete the daily exercises. All participants were initially assessed for maximum phonation times, maximum phonational frequency range, and phonation quotient. This assessment was conducted again at the end of the 4-week treatment period. Each participant engaged in one-on-one instructional sessions 4 times a week with a graduate clinician and received feedback regarding the vocal function exercises. In addition, each participant was asked to complete the exercises 2 times twice a day. The results showed that both groups resulted in increased maximum phonation times and phonational frequency ranges. though participants who were in the monitored group improved significantly more than those participants who were not monitored. Phonation quotients were greater for the monitored group, but were not statistically significantly different from those participants in the unmonitored group. The rationale behind my study is that there has been research conducted to analyze the perception of vocal quality on individuals with voice disorders, individuals without voice disorders, and on individuals who have undergone surgery. There has also been research on the effectiveness of vocal function exercises in normal and disordered vocal quality, but there is not enough research analyzing the effectiveness of vocal function exercises on the individual's perception of vocal quality using the voice-related quality of life quiz. My research study sets out to analyze this information. The purpose of my study is to analyze the perceived effectiveness of vocal function exercises related to the voice-related quality of life quiz from the patient and the caregiver's perspective. Vocal function exercises have been proven to increase laryngeal strength and increase vocal loudness, therefore increasing the patient's overall perceived vocal quality. I will be using a single subject ABA research design. These results will indicate the patient's perceptions of vocal quality before treatment and after treatment with the use of vocal function exercises during the treatment weeks. Also included, for comparative purposes, will be the caregiver's perceptions of the patient's vocal quality. The Voice-Related Quality of Life Quiz, or the VRQOL, which measures perception of vocal quality, will be provided for both the patient and the patient's caregiver to fill out as the pre- and post-test. Vocal function exercises will also be conducted during the treatment period. The patient who participated in this study, let's call him Bradley, is an 81-year-old male who was diagnosed with idiopathic Parkinson's disease in 2006. He also has dysphonia and severe hypokinetic dysarthria, which significantly reduces his speech intelligibility. He presents with impaired vocal loudness, reduced phonatory respiratory efficiency, weak glottal closure, intermittent strained voice quality, and vocal stoppages. He was the vice president of a major corporation and has traveled all over the world with his wife and 4 children. The patient attended every session with his daughter, who was taught to instruct him during his home program, which consisted of the vocal function exercises done during therapy. The patient's daughter reports that the patient is frequently asked to repeat due to reduced loudness and decreased speech intelligibility. She further states that anger and frustration improves his clarity of voice and speech due to increased loudness at those times. Now, I would like to talk to you about the therapy approach used during this study. The patient was seen for 10 sessions in which therapy targeted speech intelligibility, phonation, and vocal loudness. Speech intelligibility was targeted through the use of compensatory strategies such as over-articulating and slowing rate of speech. Phonation and vocal loudness was targeted using vocal function exercises. But for the purpose of this study, we will just be looking at the effectiveness of the vocal function exercises, and we will not be looking at the speech intelligibility. During the session, the patient was asked to do each exercise 5 times as opposed to the typical 10 due to his increased fatigue. The patient was also instructed to do the exercises once a day, every day, as a home program. I would now like to briefly discuss the voice-related quality of life quiz used as the pre- and post-test. The VRQOL is a perceived measure of vocal quality. It has the patient think about how often a problem happens and how severe the problem is as related to voice. The rating scale that the patient uses is 1 through 5, 1 being not a problem and 5 being as bad as it can be. The patient is asked to answer questions 1 through 10 using this 1 through 5 scale. Questions 4, 5, 8, and 10 assess social emotional perceptions, such as I am feeling anxious or frustrated because of my voice, or I get depressed because of my voice. Questions 1, 2, 3, 6, 7 and 9 assess physical functioning perceptions, such as I have trouble speaking loudly or being heard in noisy situations because of my voice, or I have trouble using the telephone because of my voice. Once the patient has finished, his scores are totaled, and this is used to identify a severity rating. Data collection. During the initial diagnostic session, the patient and his daughter were each asked to complete the voice-related quality of life quiz with their own perception of Bradley's voice. Then, at the end of the 10th therapy session, the patient and his daughter were once again asked to rate their perception of the patient's voice using the VRQOL quiz. The quiz severity rating scale is as follows. A score of 10 is excellent. A score of 20 is fair or good. A score of 30 relates to poor or fair. A score of 40 on the quiz relates to poor, and a score of 50 is the worst possible. The following are the results of the study. The patient's perception of his voice at pretest rendered a score of 30, or poor to fair, and post-test was 26, also a severity rating of poor to fair. These scores indicate that he perceives his voice to have slightly improved in vocal quality over the course of the treatment, but not enough to fall within a better severity rating. The patient was asked before the post-test VRQOL quiz was conducted if he felt the exercises had improved his vocal quality, which he stated he had noticed mild improvements. Although the score had improved from pre to post-test, the overall severity rating was still the same. The caregiver's perception of the patient's voice rendered a score of 30, or poor to fair, at pretest, and a score of 31, poor to fair, at post-test, which indicates she perceives his vocal quality to have slightly declined. The patient's caregiver was also asked prior to the post-test VRQOL quiz if she felt the exercises had improved her father's vocal quality, which she stated she had perceived dramatic improvements at home. This does not match the score she provided on the VRQOL. The results of this study indicate that there was no significant statistical change in the patient's voice-related quality of life through the use of vocal function exercises. Here you will see two charts, one containing the patient's VRQOL scores and the other showing the caregiver's VRQOL scores. On the individual charts, you will see that there is pretest and post-test information along the bottom and the VRQOL score along the left side. The light purple color shows the total VRQOL score. The dark blue color shows the social emotional perception, and the light blue color shows the physical functioning perception. As you can see with the patient's perception, his total VRQOL score was reduced from pre-test to post-test, which indicates that he perceives his vocal quality to have slightly improved. You can also see this with his social emotional perception and physical functioning perception. If you look over at the caregiver scores, you will see that the total had increased by 1, indicating a perceived decline in vocal quality. The social emotional perception increased, showing perceived declines in social situations, and the physical functioning perception decreased, indicating slight improvement. Results relating to the literature review. The results of the patient's perceived vocal quality indicate that he rated himself similarly to what the patients with voice disorders did in Hogek Yin and colleagues' research study. The individuals who participated in the study who had voice disorders rated their vocal quality as poor. The patient in this study, who also has a voice disorder, rated himself as poor to fair. Unfortunately, there were no perceptual improvements in the vocal quality seen with the use of vocal function exercises. It should be noted, though, that the literature reviewed for this study on vocal function exercises were based on statistical findings, such as phonational frequency range, maximum phonation times, and phonational volume, not perception of vocal quality, in which this study was based on. I would like to discuss the limitations of this study. During therapy, the patient and his caregiver learn more about what vocal quality consists of and become more aware of the patient's vocal quality through the use of the one-on-one instructional sessions of vocal function exercises than they knew during the pre-test. It is possible that over the course of the 10 sessions, the patient became more knowledgeable and aware of his vocal quality and rated himself based off his new perceptions on the post-test as opposed to what he knew before when filling out the pre-test. This could result in the little perceptual change seen in both the patient's and caregiver's scores. The patient in this study has idiopathic Parkinson's disease, which is a degenerative disease, meaning symptoms will get worse with time. It is possible that no significant gains will be made with this patient due to his diagnosis. This significantly limits the outcome of this study. Another limitation to this study is that it is only a single subject design, so the study has high internal validity and low external validity. This means that the results established in this study are relevant and beneficial to my patient, but that the results may vary when generalized over a larger population of individuals. Furthermore, treatment only lasted 10 sessions, which does not allow for much improvement to be seen, especially if the patient is not participating in the home program as he should. Another limitation is inter-judge reliability was compromised during this study by only having one examiner who was also aware of the purpose of the study. Since there was only one examiner throughout the study, the threat to validity of unintentional alteration of the participant in the data is also increased. In the future, it may be beneficial to instruct the patient on awareness of vocal quality before giving the pretest VRQOL. This could result in more accurately assessing the patient's perceived vocal quality during the pre- and post-tests. It would also be beneficial to increase the subject size to increase external validity, as well as increasing the length of treatment throughout the study. More examiners unaware of the study should be included in the next study, allowing for inter-judge reliability and increased validity of unintentional alteration of data.